for the opportunity to talk today. I was asked to talk about normal pressure hydrocephalus, and that's for sure something that greatly interests me. So I'm happy to talk about that this evening. So as you mentioned, I'm working at Rikshospitalet in Oslo. So for those of you not so familiar, Oslo is here in Norway, and this is the hospital. So I combine activity clinically and in research. So vascular and CSF is both topics of research and clinical activity, and also skull-base surgery then. So normal pressure hydrocephalus is also a topic that I'm very interested in and happy to talk about. So just to comment, normal pressure hydrocephalus also is denoted chronic adult hydrocephalus. The more correct term would be idiopathic normal pressure hydrocephalus, which is then differentiated from the secondary normal pressure hydrocephalus. The secondary type is usually caused by bleeds or trauma or infections. So the topic of today is about idiopathic normal pressure hydrocephalus. And this is a short agenda of my talk. I will ask, what is idiopathic normal pressure hydrocephalus? This is a disease that is not so precisely defined, and it also creates issues or challenges regarding selection of those patients that should be treated surgically. And then we essentially talk about shunt surgery. And I also would like to address the pathophysiology of idiopathic normal pressure hydrocephalus. I think that the audience should probably shut off the microphone.
Sorry, I will turn off all the microphones now. And now you can turn on your microphone, Professor. You can turn on your microphone. Professor, you can turn on your microphone.
Yes, okay. You hear me now.
Okay.
So again, I also want to address the pathophysiology of this disease. So to begin with, idiopathic normal pressure hydrocephalus is a severe brain disease. It's accompanied with increased mortality. So this is important to note. And here we have numbers from one study from Sweden, where they reported improbable idiopathic normal pressure hydrocephalus, a 5-year mortality of close to 88%, and also a hazard ratio for death close to 4. So there is increased probability of a deadly outcome with this disease. I think that's an important aspect to bear in mind. And another important aspect, also from studies in Sweden, is that the occurrence of INPH, or idiopathic normal pressure hydrocephalus, is higher than we usually have considered. So in this one study in neurology, the 5-year or the prevalence in people above 80 years of age was 5.9%. And this is a very high number. And another independent study from Sweden, then the prevalence of idiopathic normal pressure hydrocephalus in people aged above 80 years was actually 8.9%. So this is a disease that increases in occurrence with aging. And this is relevant because in very many countries, the age of the population is increasing quite drastically. Our country, Norway, is a rather small country. It's only at least small in size in regarding population. We have a population of 5.4 million people. And in this country, those aged above 80 years currently is about 220,000 people. It's about 4.2% of the population. And this is expected to double in a few years. And people getting older, they are more healthy. So in that sense, I think that this is a disease that actually will become more important also in the future. So then to say something about the history of normal pressure hydrocephalus. So the history of this disease started in 1965. Researchers from Boston reported in the New England Journal of Medicine 3 cases that had dementia and also cognitive dementia and cognitive disturbance, and also gait disturbance. And they found that lumbar puncture revealed a normal pressure in these patients, but they responded favorably to CSF diversion. And they denoted this situation in these 3 cases as normal pressure hydrocephalus. At that time, they didn't have CT or MRI, but they had pneumoencephalography, and they showed then large ventricles. So this was the start in 1965, and the history thereafter was that patients with these symptoms, they received shunt treatment. So CSF diversion was obtained by placing a catheter in the ventricles, and then draining either to the heart or to the peritoneum, and they then experienced clinical improvement. So this is just one example to illustrate this fact that in patients, drainage of CSF may improve clinical symptoms. And here we see one patient with severe gait ataxia, not able to walk by himself. And this patient then receives a ventriculoperitoneal shunt. And after 3 months, there is an obvious improvement in gait, one of the problems with this disease. So it's quite obvious that in some patients, drainage of CSF using a shunt may improve clinical function. So this was also what was observed after this first report. So from this first report in 1965, there was a great enthusiasm, and many thought that it would be possible to treat dementia in general by CSF drainage. And many people received a shunt for their symptoms. And in a way, as expected, this resulted in a lot of complications, poor results of surgical treatment. And this was then followed by a great disappointment. and actually the results were rather catastrophic, so to say. So after that first period, this was then followed by a great deal of skepticism, also among healthcare personnel and those involved in treating neurological diseases. At the same time, there has been a continued clinical interest and also interest in research on this disease. So I think it's correct to say that these two opinions or attitudes have followed in parallel during the years thereafter. But in several ways, we also see some kind of renaissance regarding the interest in this particular disease. So idiopathic normal pressure hydrocephalus is then defined by the following. It's basically the clinical symptoms of gait ataxia, incontinence, dementia, and it affects older people. It's persons above 60 to 70 years of age, and the typical patient is around 70 years, and they may have variable degree of these different symptoms. And nowadays, when we have both CT and MRI, then enlarged ventricles may be revealed on radiological assessments. CSF dynamics may be assessed in some places. Not all institutions do that, but then it may reveal abnormal CSF dynamics. The only treatment for this disease is CSF diversion and typically shunt surgery, and then clinical improvement may be seen thereafter. So there is a selection among 3 options. The most important treatment is the ventriculoperitoneal shunt. Some institutions also favor the ventriculoatrial type of shunt, and there seems to be some increasing interest in using also the lumbar peritoneal shunt. But so far, the VP shunt has been most commonly used. I will not go into the details about shunt surgery today, since this is in a way a topic of itself. I want more to address the disease itself and why we try to treat this particular disease. And regarding the technical aspects of shunt surgery, there are a lot of different shunt valves on the market, and there are shunt valves with adjustable valves and anti-siphoning devices, and a lot of shunts on the market. I will not go into the pros and cons of these particular devices here today. So again, a bit back to the history. As I commented on earlier, the first enthusiasm was followed by bad results and then skepticism towards the diagnosis and effect of treatment. So in a way, this is reflected by this systematic review from 2001. So it's more than 20 years ago, and the authors gathered 44 papers, and the results were not very good. Short-term clinical improvement in 59% of patients, and long-term clinical improvement in only 29% of patients. So in 1/3 of those treated, there was a long-term clinical improvement. That's not good at all. And on the other hand, complications of shunt surgery were rather common, 38%. And and permanent neurological deficits or death in about 6%. So these results were not very promising for treatment of this disease, and this understanding at this time heavily impacted how also neurosurgeons and neurologists looked at the disease and the surgical treatment, because there has been and is basically one treatment for the disease. It is the shunt operation. Some have tried endoscopic third ventriculostomy, but the results in this type of communicating hydrocephalus are not so good. So essentially, it's a disease treated by shunt surgery. But during the years, there has been an improvement in treatment results. So despite this early disappointment, people have continued doing surgery in these patients, and we can see that the results have for sure become better. So this is again a review from UK, and the more recent studies then have shown that results of shunt surgery for sure has become improved. After 3 months, the improvement was seen in 81% of patients, and the percentage of patients improved 1 year after surgery was 82%, and after 3 years, 73%. So these numbers were then based on 30 studies since 2006. So the clinical improvement has improved over years, and the opposite is seen regarding complications. The complications complication rate has for sure also improved during the years. So looking at studies from the 1970s and then to after 2006, we can see that the mortality associated with the disease has for sure gone down, and the occurrence of other complications also has gone down. And as listed here, shunt surgery in older patients, of course, have complication risk. There are risks of hematoma, infection, and also the need for further surgeries later on. So it's not complication-free to do shunting surgery in these patients, but apparently the results have improved. So this was a systematic review from 2013, 10 years ago. A more recent study, including even more patients, then looking at results of shunting. And then we see that the VP shunt is the most commonly used. And in this review, the number of patients was quite high, 1,812 patients, while fewer studies have been done regarding the ventricular arterial shunt, and even fewer with the lumboperitoneal shunt. Again, we see the same numbers here. The improvement is close to 80% with clinical improvement. And it can be seen that the gait improvement is most apparent. It's most evident, while then in these studies, the incontinence part of the disease is then lowest, with cognitive impairment in between. And again, we see here complications are seen after shunting surgery, and subdural collections in about 9%, and ischemic hemorrhagic events in about 2% of patients. And there also is mortality associated with shunting of idiopathic normal pressure hydrocephalus. So there are the potential for complications. But anyway, we see here gathering many patients, a rather large study, that the results are overall rather good. So one may ask, what has happened from this early period with bad results? And obviously something has happened. Results have become better. Complication rate has gone down. And we may discuss why is it so? So is it because of diagnostic criteria? Because diagnostic criteria has come regarding this disease. The radiological markers of INPH also may have improved. Is it the use of CSF dynamics assessment? And what about understanding of the disease, the pathophysiology? And we will look at this. I would say probably a combination of different factors that have contributed to the improvement in outcome of treating this disease. So which role has the diagnostic criteria? Diagnostic criteria was introduced in the beginning of 2000. We have the American European from 2005, and the Japanese guidelines that they have been updated several times thereafter. In general, we differentiate between possible and probable INPH. The difference between these two types are that in probable, then the lumbar CSF pressure has been measured, and a normal lumbar CSF pressure has been found. The Japanese guidelines also use the term definite INPH, meaning that the patient has responded clinically to CSF shunting. There is a problem with the diagnostic criteria, and the problem is that the criteria itself does not say anything about the chance of improving after shunt surgery. So therefore, they also differentiate between shunt responders and shunt non-responders. So there are weaknesses regarding the diagnostic criteria. And let's look at the Japanese guidelines, because they are the most recent one. And this is how they do it in Japan, where, again, the clinical presentation is on the top, obviously. And as we talked about, the clinical presentation of idiopathic normal pressure hydrocephalus is the combination of gait disturbance, incontinence, urinary incontinence, and then the dementia or cognitive part. So one of these aspects of the triad should be present. Patients should be older than 60 years of age, because this is a disease of the elderly, and radiological assessment should present increased ventricular size. So then there are different radiological criteria or presentations that we will comment on later on. And in Japan, this dash sign is given a priority, so to say. CSF investigations may be done using the TAP test, and at the same time, it's possible to measure the lumbar CSF pressure. And if this is normal, then the patient enter from the possible to the probable type. And if surgery is recommended and there is a shunt response, a clinical response to the surgical treatment, then the patient is denoted definite IMPH. So looking at this, we see that strict criteria of the disease is in several respects lacking. So both the clinical and the radiological presentations are not very specific as compared to what is seen in aged people. So, of course, there are some challenges regarding the current guidelines. So, what about the radiological markers of the disease? And as we said, in Japan, the dash sign is given priority in the guidelines, as we can see here. And this is a marker that is used worldwide, and it stands for disproportionately enlarged subarachnoid space hydrocephalus. So the typical sign is that there is a flattening of the brain at vertex. It's in a way, the brain is in a way lifted up, and there is disproportion between the subarachnoid spaces in the sense that there is minor CSF spaces at the vertex, while the sylvian fissure is typically enlarged. So this sign is a lot used regarding the radiological assessment. Now, another sign is the callosal angle, and this should be measured in the posterior commissure, and it's this angle that is then used. The thresholds are somewhat variable in different studies, but if this angle is being narrowed, for instance, below 90 degrees, it's considered a radiological marker of the disease. These signs are not extremely specific, as it may also be seen in other situations. So again, this is another study highlighting that in normal pressure hydrocephalus, then the ventricles in a way and the brain is in a way lifted up towards the vertex, as we can see here also regarding the callosal angle that is becoming narrower. So these markers, as I commented, they are not extremely specific. In this systematic review, the diagnostic odd ratio for that was found significant in these different studies. Then the callosal angle had a diagnostic odds ratio of 1.88, and periventricular white matter change DOR of 1.0. So these radiological markers alone, they are not very specific. But again, in clinical practice, then we combine the different radiological markers that hopefully increase the predictive ability of these markers. So going further, what about CSF diversion and testing the clinical response to CSF diversion? This TAP test has been used for quite many years. It has a good positive predictive value. These are numbers from a European IMPH multicenter study. And we can see that the positive predictive value is rather high. The problem is a rather low negative predictive value. So in other words, if the TAP test is normal, it tells little about the chance of shunt response. And this is from another systematic review, including quite many patients. And again, we see that the positive predictive value is generally quite high, while the negative predictive value is low. So the TAP test is used extensively, and for sure it tells something. If the test is positive, is the patient improve after tapping of CSF, then it's diagnostic useful. But if you have a negative test, then you have less diagnostic benefit of the test. So it's important to be aware of this limitation regarding the TAP test. And in particularly the USA, then also the extended lumbar drain has been useful or used a lot. And this is one example. This is before extended lumbar drain, and this is after, and it's quite obvious. This patient, there is an improvement. So this patient then had a lumbar drain for 2-3 days, and the clinical improvement was tested. So this is another way of testing the chance of improving after shunt surgery. What about biomarkers in the CSF? Then currently there is limited information. This is one systematic review that found that higher levels of tau, total tau, or phosphorylated tau in the CSF was accompanied with non-response to shunt. So this is probably an indication that the level of neurodegeneration impacts results. So increased neurodegeneration is a negative predictive factor for shunt response. So I also wanted to say some words about CSF dynamics testing, because this has been a topic of interest in this department for many years. So we have observations on this that also shed light on the problem of the disease, what's happening in the disease. So what we have used is the lumbar infusion testing, particularly during the 90s, and we have for many years also used measurement of pulsatile intracranial pressure overnight, and in addition to imaging. So this has also then provided some insight regarding the pressure dynamics that are abnormal in normal pressure hydrocephalus. So this is from infusion testing. Then a needle is placed at the lumbar level and connected to an infusion system, and the pressure response to the infusion system is measured. So this is from intracranial pressure monitoring, and that is something we have done and do in these patients. This is the patients that we saw earlier on. Obviously, something has happened in this patient after shunting. This is the pressure recording in this patient. And here we have two trend plots showing the overnight measurement of intracranial pressure in the patient. This is the ICP itself, and this is the pulsatile ICP, the mean wave amplitude. So what we can see is that the intracranial pressure is normal in the patient. The average is 3.1 millimeter mercury. So in a way, the name of the disease is correct. It's normal pressure. It's normal intracranial pressure. But what is not normal is the pulsatile pressure in these patients. So this is the curve for the mean wave amplitude. And the mean wave amplitude refers to the pressure change from diastole to the systole. And then we measure this for a long time, so we get a very good picture and information how this is in the individual patients. So here we can see that the mean wave amplitude, the average of this, is 5.9 millimeter mercury, while we have a threshold of 4 millimeter mercury. So in this patient, the pulsatile intracranial pressure was heavily abnormal, despite a normal mean intracranial pressure. The ICP that most are used to think about, that was very normal in the patient. So we have looked at this also at the group level. So this is from an earlier publication, including 130 patients shunted for IMPH with a median follow-up of 2 years. And what we found was that there was a really high and good both positive and negative predictive value for shunt response if the pulse amplitude or the mean wave amplitude was above defined threshold. And the threshold we use is 4 millimeter mercury. We did not find the same for the intracranial pressure itself. So in those responding to shunt surgery, there is abnormal pulsatile intracranial pressure. So some aspects of the intracranial pressure is not normal, even though the disease is denoted normal pressure. So this is important to bear in mind, because it also tells something about the mechanisms behind the disease and also the role of shunt surgery. So other people have done also a systematic review and meta-analysis regarding these CSF dynamics assessments, and this amplitude assessment I just talked about had a very high diagnostic odd ratio. Also, the extended lumbar drain had a rather high diagnostic odd ratio and somewhat lower for infusion tests and tap tests. But anyway, these types of tests are useful, and they are increasing the predictive ability of or the prediction of shunt response in these patients. So I then wanted to turn over to the pathophysiology of IMPH. Which kind of disease is this? And I would argue that this is basically a neurodegenerative CSF disease. As neurosurgeons, we have been essentially addressing the CSF disturbance part of the disease, and in a way looked at this as only as CSF disturbance disease. And this is not entirely correct, because there is another extremely important component to the disease, the neurodegenerative aspect. So in several respects, IMPH is a dementia disease, like Alzheimer, Parkinson, and other kind of neurodegenerative diseases. So I wanted to address this and then first look at the CSF disturbance part. And this can be examined in different ways. And just to give an illustration here, where we, in one study from our group, we used phase contrast MRI of the Sylvian aqueduct. So we look at flow, and then we looked at flow velocity at each pixel of the Sylvian aqueduct. And we looked at this during the cardiac cycle. And then the CSF flow in the Sylvian aqueduct is going upward and inward. So it's also possible then to determine the net flow of CSF. And what we found was that both the direction of flow and also the volume of flow is very variable in these patients, and it's different from the normal. So in the Sylvian aqueduct, as would be expected in healthy individuals, then the flow is from the third ventricle to the fourth ventricle. It's out from the ventricles, but in many patients with normal pressure hydrocephalus, actually the flow is from the fourth ventricle to the third ventricle. It's opposite. So the direction of flow has changed, and the volume of net flow is also variable between the patients, but the volume is very much higher than we usually have learned from textbooks and what is generally taught. So for sure, there is a change in CSF flow in patients with normal pressure hydrocephalus. This can also be seen when we inject tracer into the cerebrospinal fluid at the lumbar level of these patients. Then the typical thing is that the tracer is actually going from the thecal sac and then directly into the fourth ventricle and to the third and lateral ventricles. And the tracer is staying there until the next day. So this is another perspective that actually there is a redirection of CSF flow in idiopathic normal pressure hydrocephalus, as opposed to, as shown here, reference subjects, where we don't see this kind of reflux of tracer into the ventricles. So obviously there is a change in CSF flow in normal pressure hydrocephalus. And this kind of reflux of tracer is something that we actually use clinically nowadays. And we have graded the degree of reflux. And the typical thing is that in normal pressure hydrocephalus, then there is a reflux grade 3 or 4 in these patients, meaning that the tracer is typically staying there the next morning after injection and thereafter being washed out the next days. So this was just to comment that CSF flow is changed. And again, to bridge towards the intracranial pressure measurements, patients with the highest degree of reflux, they are also the patients that have these abnormal pulsatile intracranial pressure. So they have improved or impaired impaired pressure volume compensatory reserve, and also redirection of the CSF flow. Then from the CSF flow aspect towards the neurodegenerative aspect. So this is important because there are a wide range of changes at the glia neurovascular interface in idiopathic normal pressure hydrocephalus. So because we have biopsies of the brain during shunting surgery, we have been able to address what's actually happening at the tissue level in the patients. And what is typical of these patients, they have disruption of the blood-brain barrier, and they have leakage of blood proteins to the tissue. And then we are at the level of the capillaries. So this is important as there is a loss of integrity at the microvasculature in the patients. And this is accompanied by astrogliosis. And astrogliosis means that astrocytes, the glia cells, they are becoming reactive. They are changing their normal configuration, and there is some kind of reaction in these cells. And we also find that the density of aquaporin for water channels is decreased at the astrocytic end-fit processes, because the astrocytes and their end-fit, they form some kind of tunnel along the microvasculature of the brain. And these water channels, aquaporin 4, they play a role in the normal water homeostasis at the capillary level, and the function of the glial or the end-fit of the astrocytes. So there is also a change in the aquaporin 4. And what we also see is that there is accumulation of amyloid beta and tau in the brain, in the interstitium of these patients. So this is an important thing, and this has been previously pioneered by our Finnish colleagues, particularly in Kuopio, and they have for many years obtained brain biopsies during shunt surgery, and some years ago they reported results and then reported that accumulation of both amyloid beta and tau was seen in 10% of the patients, and only amyloid in about 33% of the patients, and in 57% of the patients there were no accumulation. So this is important because accumulation of amyloid beta and tau is the typical of Alzheimer disease among and also other neurodegenerative diseases. In Finland, they also have addressed the genetic aspect of the disease. This is also important because they have found that up to 20% of patients with IMPH, then there also is other family members with the disease. And up to now, these genes have been shown to be affected in idiopathic normal pressure hydrocephalus. So this is important as it also links this disease to other neurodegenerative diseases. So what we know is today, and this has become more clear during the last years, is that CSF has a role in the clearance of waste from the brain. So our brain, there is a production of about 3 to 4 grams of proteins each day. And if the normal clearance is being impaired, then there is an accumulation of these toxic metabolites. And this is the issue in dementia diseases. So like Alzheimer and traumatic brain injury, and also idiopathic normal pressure hydrocephalus, then there is accumulation of amyloid beta and tau. And in Parkinson disease, another protein is aggregating, namely alpha-synuclein. So this can be examined in tissue specimens during surgery, and there also are radiological markers of the degree of neurodegeneration. So one important thing is do we have any evidence for a coupling between the neurodegenerative and the CSF disturbance aspect in idiopathic normal pressure hydrocephalus? So then I would like to highlight the discovery of the glymphatic system. This was described the first time in 2012. And the glymphatic system is basically a brain-wide perivascular transport route for fluids, solutes, and it is thought to have an important role in clearance of waste from brain metabolism. And as we heard, clearance of waste is important since the brain is a high energy organ, requiring a lot of energy and also producing waste. There must be effective ways to remove the waste from the brain. And in this regard, the CSF is also playing an important role in addition to the other pathways. So this is illustrated here. That CSF is then in continuity with the perivascular spaces, and the perivascular spaces are then considered highways for CSF that then plays an important role in clearing the waste products. And it's thought that this occurs along the perivenous sites, and thereafter to the meningeal lymphatic system. So this lymphatic system could then link the CSF and the neurodegenerative aspects of idiopathic normal pressure hydrocephalus. So then I would like to highlight some studies that we have done in our hospital. We have used MRI contrast agent as a tracer to study how larger molecules are moving within the CSF and within the brain. So we then have used galbatorol. This is a very hydrophilic molecule. It does not pass the blood-brain barrier. It's contained outside the vasculature. It has a molecular size that is quite much larger than water, for instance, but less than these waste molecules like amyloid and tau. So we then have injected it to the fecal sac and the CSF, and then repeated MRI at several times to look how is the tracer moving. So this here we have removed the tracer from the CSF itself. So we just see how the tracer enriches the brain from outside along the extravascular parts. And as we can see, the entire brain is then enriched with the tracer. So when this tracer is given to the CSF, then we see that there is a brain-wide tracer distribution. And again, this is not via the blood vessels, it's outside the blood vessels. And we can see that the tracer distribution is from outside and inward. And we see that the tracer distribution is most extensive along the large, or the sites where the large arteries are, like the anterior cerebral artery, the middle cerebral artery, and also the posterior cerebral artery. So this distribution of tracer is relevant, we think, regarding neurodegenerative diseases. This is from a paper by Nedegar in Science, and then referring to the trace distribution that I have shown you here. And what we should note is that the trace distribution is very much similar to the distribution or the aggregation of toxic molecules in the brain of dementia disease. And these toxic molecules or proteins, we have commented, it's amyloid beta and tau, and in Parkinson, alpha-synuclein. And what can be seen is that the aggregation with increasing severity of dementia disease, then we see how the amyloid is being deposited in the brain of Alzheimer patients. And this is the tau distribution, and this is alpha-synuclein in Parkinson. And this is the tracer in the studies I've shown you. So we think that the tracer distribution is relevant for this abnormal aggregation of toxic proteins from brain metabolism. So I'm showing this to also highlight what's happening in normal pressure hydrocephalus. But this is what we see here. The typical in normal pressure hydrocephalus is that the clearance of tracer is delayed. So there is an impairment of glymphatic function in normal pressure hydrocephalus. The ability to clear molecules is being weaker or different than in normal patients. And looking at a particular region, this entorhinal cortex nearby the hippocampus, then it's quite evident that the clearance of tracer is delayed in idiopathic normal pressure hydrocephalus. And this, we think, is relevant in the sense that these patients have dementia problems, cognitive problems, and this could be linked to a delayed clearance via CSF of these proteins that are damaging to the brain, like amyloid and tau. So for that reason, we think there is a link, so to say, between the CSF and the degenerative aspect of the disease. So these studies point to what is happening within the brain itself, the delayed clearance of substances from the brain. The other aspect is the clearance to the blood, and then the process of clearing from the blood. Then we believe that the meninges and the lymphatic vessels in the meninges is important. And one thing to note is that the CSF to blood clearance is quite variable in normal pressure hydrocephalus, but the clearance process is, in the majority of patients, impaired. So the clearance is not functioning as well in these patients. causing substances to stay in the CSF for a longer period. So this is the curve for the normal pressure hydrocephalus, and these are the curves from other patients. I also wanted to show that the clearance of substances from the CSF is occurring quite much faster from the blood than the enrichment of the tracer at the vertex. So this traditional concept that CSF is basically cleared from the vertex via the arachnoid granulations is very questionable. So actually, it seems like this region is less important for the clearance of CSF. So this is a rather busy image. I just took it here because just to highlight that we don't think there is one simple cause of idiopathic normal pressure hydrocephalus. It's a multifactorial disease. Several aspects are important regarding risk factors. The advancing age is for sure important. Genetics play a role, and we have looked at different aspects appearing in the tissue of the brain, like the blood-brain barrier disruption, osteogliosis, loss of aquaporin 4 at the perivascular end foot, and there is a very relevant comorbidity against vascular diseases. It seems like the lymphatic function and also the meningeal lymphatic function is impaired in these patients. So the consequence is that there is CSF flow abnormality, and there also is neurodegeneration, and this is something we can see when exploring the tissue, the brain tissue in the patients, and it also causes changes in the pressure volume reserve. We have talked about the pulsatile isopy that is changed in these patients. So these different radiological scores that we have commented on, they also seem to be very relevant regarding these possible mechanisms in the disease process. So, of course, this is an evolving picture. We don't have an explanation of the pathophysiology of INPH today, but the understanding of the disease is at least improving over time. So we know more today than some years ago. So now I have talked quite long, and I wanted to sum up. Today, it's important to look at INPH as a combined neurodegenerative CSF disease. It's not only a CSF disease. There are other aspects. I think we have to admit that the diagnostic criteria that we have today have limitations, and this also is reflected, excuse me, in rather great variation regarding how patients are selected to surgery among institutions. But what is common in different places is that the clinical picture is highlighted, combined with the imaging features, and many places also use the clinical response to CSF diversion. The role of CSF dynamic testing is somewhat variable between institutions. I also think that it's important to highlight that actually INPH is a progressive and severe brain disease, and it seems to increase in frequency. So it's becoming a more important patient group. So then I would thank you for your attention. And if you have questions, we could have questions.
Yes, sir. This was absolutely stunning and amazing lecture. It showed all of us the pathophysiology and the importance of knowing each aspect of this disease. And indeed, in neurosurgery, which is the best specialty in the world, it shows us that everything is connected. So we must deeply understand all of these aspects. With your permission, I would like to ask questions from the chat board.
Sorry, Professor, can you stop your screen sharing so we can see each other?
Yes.
Figure? Thank you.
For sure.
Dr. Yunus Aydın asks, thank you very much for your didactic presentation. If the symptoms and images are typical, I can decide to put a ventricular peritoneal shunt without a tap test. In intermediate cases, I wait for maturation of symptoms. What is your recommendations for the intermediate cases? And do you take biopsy for checking Alzheimer's disease during shunting procedure?
Yes, we do a biopsy during a shunt procedure, and then we look at the distribution of amyloid and of tau. And the idea is to get an information about the degree of the neurodegenerative aspect. And in some cases, also it's necessary to redirect patients in other directions. And it's also a question of revision if there is a lack of response. Regarding prediction of shunt response in patients, this is heavily discussed, and there is no simple answer to this because practice is variable around the world. Many would use a tap test and also the radiological markers. That would be the common thing, of course, in addition to the clinical picture. And sometimes there will be a need for observation, and these patients are probably the intermediate cases. In these cases, it could be useful then to follow the patient and not, has the opportunity to follow the patients. I think would be smart.
So what is your recommendations? How often do we need to put follow-ups, like 3 months, 6 months?
Are you thinking about after shunt placement or before shunt placement?
In intermediate cases and after shunt placement?
Again, it's difficult to have a general answer to this question. This is, as I commented on, a progressive disease. So I think it's, in that sense, after 6 months, 12 months, then it would be useful to follow these patients. How you follow after surgery would depend on the institution. So what we do, our patients are followed by geriatricians before and after surgery because we want to have a detailed characterization of the benefit of surgery. So they do more sophisticated tests than we can do as neurosurgeons. And we also have very good help of specialized nurses that also follow the patients afterwards, because as you know, the capacity of neurosurgery is or neurosurgeons could be limited in a sense. So actually, we also have very good help regarding from our specialized nurses on this. And then the patient come to neurosurgeon if there is any problem. But happily, patients are usually very happy with the development after surgery. And if everything is nice and patients are happy, then they don't necessarily need to come to the surgeon. But if there is any problem, of course, then come. I think this would depend on the different institutions. It would be variable how you do it, actually.
Thank you for your detailed answer. Dr. Madonna Hobzadeh, the neurosurgeon from Georgia, says, thank you, Professor, for sharing your invaluable insights and experience about normal pressure hydrocephalus. I have a few questions. Number one, which type of shunt is preferable in this case? Number two, or we can do it one by one. How do you...
In a way, I would hesitate to give a name of a certain shunt. We use shunts that have adjustable valves. So I think there are some advantages, but I think it's possible to use different kinds of shunts for this procedure, and there are many shunts on the market. So I wouldn't necessarily argue that one shunt is better than another, because there are no control studies to advocate or to build on such a statement. So, but in general, we use shunts with adjustable valve.
So, but how do you determine the optimal valve setting for the shunt?
So we actually use the same valve position in all patients, and then we adjust this afterward, depending on the images, because we typically have a CT scan immediately after surgery, and then after 1 week, and also 6 weeks. So in order to avoid particularly subdural collections. And that is in a way the main thing to avoid, I would say.
So what about such complications like overdrainage?
I think overdrainage is a problem with all kind of shunt surgery and CSF diversion surgery. Then it's also often a question about the antisiphon devices, so there are good arguments for using that on a regular basis. We don't use antisiphon devices on a regular basis. We don't do that. Others do. And for sure, overdrainage issues is a challenge in all shunt surgeries.
So in follow-up periods, you do only CT, not MRI?
No, we don't use MRI in the follow-up on a regular basis. No.
And what is your long-term prognosis for such cases?
We expect in properly selected cases, we expect the response to last for years. And then after 2 years, 3 years, then you have the neurodegenerative component. And in that respect, we also find it useful to actually know how far has this proceeded, also from the tissue specimens and also these radiological markers of neurodegeneration, because there are several, like the MTA and PASECAS and different scores that we record on a regular basis.
Sure.
So
the last question from Dr. Madonna Hobzadeh. What do you think about endovascular cerebrospinal fluid diversion, like minimal invasive with miniature biometric transdural shunt?
We have no experience using that. And of course, that would be very novel and if possible to obtain good results using that treatment option, that would be, of course, very interesting and novel. So I wouldn't have strong opinions on that. We have no experience with it.
Okay. So Dr. Ilkay Shikai asks you, thank you for the great presentation. I have few questions. Do you prefer questions one by one or all in
That's
one?
okay. We can take one by one, yeah.
Okay. This is important. What is a target setting for adjustable valves? This is important in my opinion as there is no anticipated best response. At what point do you stop lowering the performance level?
I think that's a very good question. All of these questions are good. So it depends on the shunt type. For instance, if we use a Codman-Hackin shunt, programmable shunt, then we typically will have an opening pressure of about 12 centimeter water. That would be the common type. And we never will go below 8 centimeter of water. And if there is overdrainage, then we can turn it up. So I think there is no general answer to this question, and there will be different opinions on it. And I wouldn't argue that we have the final answer to that and do it the best way, because I think that the current shunts, they have limitations, and overdrainage is a problem with to a larger or lesser degree with all shunts. So and if we use another kind of strata valve, for instance, then there is another kind of valve adjustment, and then we usually would place it on 2.0 in the beginning, and then adjust later on.
Okay. So he continues, I have experienced cases of lateralization of lower body symptoms when there is ventricular asymmetry. Have you encountered such cases?
I don't have any systematic experience with asymmetric ventricles in IMPH. So my impression is that this is less common than in other kind of hydrocephalus.
Okay. So
I
when
wouldn't say that it's not a big issue in this patient group from our experience.
so it was probably other types of hydrocephalus.
It could, for instance, be a secondary normal
Yeah.
pressure hydrocephalus that then you have other pathologies, then it will be more frequent.
Yeah. When minor subjective symptoms are present alongside typical radiological findings, what is your strategy? How do you explain MRI findings that are present long before the development of symptoms?
So in general, if the symptoms are minor, then it is a question whether it's reason to advocate surgery. So there should be some kind of symptom burden, so to say, because at least neurosurgery is there is not zero complication rate. There is a risk of complications. So there should be some kind of balance between the symptom burden and yeah,
Okay.
the reasoning for shunt surgery.
Thank you.
So it's not a very simple answer to that.
Yeah, I understand. So regarding long-standing overt ventriculomegaly in adults patients with accompanying aqueductal stenosis, what is the value of the TAP test?
If there is aqueductal stenosis,
And
then I wouldn't use a TAP test in those cases. If there is no communication between the ventricles and the subarachnoid space, I don't think many would advocate TAP testing of those patients. I wouldn't do.
it is radiological confirmation, right?
Yeah, it's radiological. Sometimes the MRI, for instance, can be difficult to interpret, and then we sometimes find it useful to inject a tracer or a contrast agent in the CSF to actually verify that there is obstructions to CSF flow. That could be useful. We do that from time to time, and sometimes we have been surprised actually. We didn't see it on MRI, but after injecting a contrast agent, then it's evident.
Thank you very much for sharing your experience with us with these difficult questions. I also was wondering what type of MRI settings or regimes do you use for this tracer?
So for the tracer, we used T1 images, standardized T1 images, because we also semi-quantify the tracer enrichment. So then it's very important to use standardized regimes for MRI. But in general, it's a T1 sequences.
But can it be adjustable to regular 1.5 Tesla MRI machines?
We both use 1.5. The images I presented to you, they were obtained by 3.0, so 3 Tesla for those images. It's more sensitive, but we also in the clinical routine, then we use 1.5.
Oh, thank you very much. So Dr. Celine Bostak says, thank you for your excellent and detailed presentation. And Professor Hassan Kamil Suchu says, thank you for this amazing lecture and asks, does shunt increase the life expectancy of normal pressure hydrocephalus patients to normal? Is a life expectancy increasement?
I would expect it to improve life expectancy, yes. We don't have numbers to which degree. One of the reasons why these patients have increased hazard ratio for death is the risk of falls. So they fall and get, for instance, a hip fracture, or that, of course, is very negative in this age group. This can be improved by shunting. So I would expect surgery to improve life expectancy, even though we don't have numbers for it.
Okay, thank you very much for your answer. Dr. Bahmet asks, sorry, he couldn't listen to all the webinar, but he wants to ask what is the place of endoscopic triventriculostomy, ETV, in normal pressure hydrocephalus?
So I would say the place is rather limited, but in some patients there is non-communication. There is, for instance, an aqueductal stenosis, or there is a web, for instance, at the outlet of the fourth ventricle. So in these, at least in some of these cases, then endoscopic procedures has a place. So we do that from time to time. But if you have a idiopathic normal pressure hydrocephalus in the traditional form as a communicating hydrocephalus, then the results, we don't have good results at all from endoscopic procedures.
Yeah.
So then I wouldn't advocate it.
Okay, thank you very much. And if you may, I would like to ask one more question too. Currently, I'm being in a neurosurgery program, but I'm also curious in neurophysiology, like you. And what is your general advice? How can we pursue our career in neurophysiology, in science, in researchers? Is it possible for people from Kazakhstan? We don't have that much laboratories, for example.
So how is the best way? I'm not sure whether I understand the question.
Is it possible to people from not highest income like Europe, like USA, to also do researches and investigations in brain area, in neurophysiology?
Okay, whether it's possible for people in institutions where the resources are more limited as compared to those with. Yes, I think so. It's also always a question in research which kind of studies you are able to perform depending on the economy of the project. I still think there is opportunities for research for sure, independent, also in institutions where there are limited resources. Depends on the method and the research questions, and so I think that's actually important to do. I think very much of the improvement in neurosurgery as well has also developed from limited resources historically. So I think the answer is yes, I think so.
Thank you very much for your answer. And also Professor Andriy Netluk from Ukraine.
Yes. Professor Netluk is participating from Ukraine, from Levy, and this is the war zone. So I want to hear his opinion because he has no much time to participate.
Hello, thank you very much for the excellent presentation. It's very important and work because we all deal with these cases, and sometimes, and it's usually it's not easy to make the correct decision. So the information is very useful, and I think everybody will use it in the everyday practice. Thanks.
Thank you.
Thank you, Andrew. And
Thank
if
you,
I want to hear from Madonna, a young neurosurgeon from Georgia.
Thank you very much, Professor. It was truly invaluable insights and your experience. You answered all my questions. Thank you, Ayman, for asking on behalf of me. I have a weak internet connection. So thank you again, Professor.
Thank you.
Thank you so much. And if anyone else who want to comment in the end of the conference, we can. Bektaş abi, would you like to say something?
Yes, thank you, Professor, for your excellent lecture. You showed us the clinical part of the situation, disease, and also showed the part of the research projects. Thank you very much. Thank you.
Yeah, thank you as well.
And Dr. İşkay, do you have any last comment or?
It was a great joy for me to listen, Professor. And actually, I would like to share my experience with the question
Yeah,
I asked.
you can.
No. I would like to share the MRI images of lateral ventricular asymmetry and lower body symptom asymmetry as well, lateralization as well, with him, if he doesn't mind, if you don't mind, Professor. I would like to I would like to contact with you an email if it's okay for you.
Yes.
And I would like to learn your, opinion about these, if it's possible.
Yes, of course.
Okay, thank you.
I must say we don't see very many of asymmetrical ventricles in IMPH, but please just provide me with the images and we can discuss that. Yes.
Okay. Thank you very much. It was great pleasure for me to listen. Thank you very much.
Thank you. Thank you.
Okay.
Now we're curious too.
We finished all the questions and comments?
Yes.
Okay. So I want to thank again to Professor Eide. How can I pronounce your surname, Professor?
Eide is Eide. Yeah.
Eide. Okay. I want to thank again Professor Eide, and I want to thank everyone who participated today, this evening, this morning.
And I myself would like to thank you for listening. So it was
thank you so much.
Great talking to you.
Bye.
Thank you.